Now, the next is ashmari chikitsa. अथातो अश्मरी चिकित्सितं व्याख्यास्यामः यथोवाच भवान् धन्वन्तरिः अश्मरी दारुणो व्याधि अन्तकप्रतिमोदः औषधैः तन्न साध्यः प्रवृद्धः छेदप्रहृति तस्य पूर्वेषु रूपेषु स्नेहादिक्रमेष्यते तेन अस्य अपचयं यान्ति व्याधेः मूलानि अशेषतः. Now ashmari is considered to be one of the very serious disease condition. Of course, more details about that issue we have discussed during the Nidanasana discussions as such, and it's considered as a almost fatal conditions, and only in the early stages medical treatment, medical management would be the option, and in the later stages surgery is indicated. So Srishuddha has suggested a protocol of devising the medical management and the surgical management, and in the Pururupa, before it occurs, the Snehana and the Shodhana Chikitsa is one of the best possible preventive treatment. So by giving the or by using the Shodhana Chikitsa, the disease would not occur. Now, when it comes to the question of that critical issue of this devising, like when the surgery has to be done or when the conservative management can be done, in the current situation, of course, there is no question of a preventive treatment in terms of the Shodhana. That Shodhana Chikitsa is not there. And in Nidana, we have discussed that part also, that Asam Shodhana Shilasya, that one of the causes for the Ashmari is the not having the habit of regular Shodhana. So that part is not correct seen in the current situation. Whereas the other conditions, there are certain universal guidelines to deal with the cases of the stones there. Now, the cases of the stones in the bladder stones, the latest, the current guidelines are by the EAU, European Association of Urology 2019, which says, like in case of the vesical stones, bladder stones, asymptomatic migratory bladder stones in adults may be left untreated, especially if the stones are small. Primary and secondary bladder stones are usually symptomatic and unlikely to pass spontaneously. Active treatment of such stones is usually indicated. So secondary stones, in the sense, these stones which are produced as a result of the other diseases. Most commonly it is the prostatic hypertrophy. Then the stones composed of uric acid or fluoride can be dissolved by chemolysis, and uric stones can be dissolved by urinary alkalization. When a pH is more than 6.5, is consistently achieved. So alkalizers are suggested as the medical treatment now, is a protocol now, and usually using alkaline citrate or sodium bicarbonate, and monitoring is necessary during that situation. And the uric acid stones also can be dissolved by irrigation chemolysis by a two-way or three-way Foley catheter. So irrigation also can be done into the bladder. And bladder stones can be treated with open laparoscopic, robotic assisted laparoscopy or endoscopic surgeries. So different interventional options are suggested in case of the bladder stones. Then suprapubic cystolectomy is also associated with the catheters and longer hospital stay, but it's done only in very large cases as such. And in adults and children, transurethral cystolithotripsy is the other standard protocol of the treatment now, which is considered to be safe. Then bladder stones in men aged over 40 years are typically related to benign prostatic hyperplasia, the management of which should also be considered. Bladder stones formed after bladder augmentation may be removed via open cystolectomy. This is about the post-operative conditions, which is not an important issue. So the important is that kind of a definition where surgical management is required and where medical management is required. Now, as far as the renal stones, renal and ureteral stones are concerned, again the guidelines, UAE guidelines are, if it's a ureteric stones and if it is in the proximal end of the ureter, now of course there is no question of medical management, it's only the intervention, and the interventions are usually of a mild, moderate intervention or mild intervention or a more deeper interventions. Now, in the standard guidelines are, if it is less than 10 millimeter in the proximal side, then the usual suggested treatment is either ureteroscopy or the shockwave lithotripsy. Whereas if it is in the distal and if the size is more than 10 mm, then it may even require the percutaneous lithotripsy also. And if it is in the distal side of the ureters, like, and if the size is less than 10 mm, again the same options are suggested. And if it is more than 10 mm, then again the lithotripsy or shockwave lithotripsy is the suggested treatment. In case of the renal stones, the lower pole stones are usually more difficult to be managed, and the non-lower pole stones are usually easy to be managed. And then again, it depends upon the size, 10 mm and 10 to 20 mm and more than 20 mm. And the options are again have different options, like either lithotripsy or maybe the open pyolithotomy. Open surgery also is required in case of the bigger stones. Now that's about the protocol. Now, all the point of highlighting this is, Sushruta has said that pravurdha chedamarhati. He has not mentioned about these objective sizes. Now, aushadaihi tarunah sadhya pravurdha chedamarhati. In that taruna and pravurdha, we have to interpret in these lines of the current guidelines as such. Now, as far as the medical options are concerned, the drugs which are suggested are पाषाण भेदो वसुको वशिहि आश्मन्तकौ तथा शतावरी शतंसा च बृहती कंटकारिका कपोतवंका आर्तगलः कच्चक उशीर कुब्जकाः वृक्षादनी भल्लुकश्च वरुणः शाकजं फलं यवाः कुलत्थाः कोलानि कटकस्य फलानि च ऊषकादि प्रतिवापं येषां क्वाथैः घृतं वृक्षादनी भल्लुकश्च वरुणश्शाकजं फलं यवाः कुलत्थाः कोलानि कटकस्य फलानि च ऊषकादि प्रतिवापं येषां क्वाथैः विसंकृतं भिनत्ति वातसम्भूताम् अश्मरीं क्षिप्रमेमतो क्षारान् यवावूर्यूषांश्च कषायानि पयांसि च भोजनानि च कुरुहिता वर्गे अस्मिन् वातनाशने. In case of Ashmari, the options of the treatment are Pashana Bheda, Vasuka, etc. Now, in the Nidana, we have considered the most of the stones, oxalate stones types, as maybe the Ashmari, or the other way of looking at the dosha in case of Ashmari is when the patient presents with a quality pain due to the moving stones, that also could be considered as a Vataja condition. Then in case of the Pittaja conditions, Kushaha, Kashaha, Sarvo, Gundra, Idkato, Morato, Ashmabhit, Vari, Vidari, Varahi, Shali, Murate Kantakam, Bhallukaha, Patala, Patha, Patturo, Athakuruntika, Punarnava, Shirishashta, Kotidaha, Teshisadam, Kritam, Shilajam, Madhuka, Bijihi, Indi, Varasita, Tapusa, Yervarkadinam, Bijeshta, Avapitam, Shubham, Pinati, Pittasambhutam, Ashmarim, Shipramevato. क्षारान् यवागून् यूषांश्च कषायानि पयांसि च भोजनानि कुर्वीता वर्गे अस्मिन् पित्तनाशने. Now, in a case of Pitta Ashmari, the drugs like Tunapantamula and then all that Pittahara Aushadis, any of them or all of them could be used in the form of either Ghata or Kshara or Yavagu or so on, the options. Now, as we have discussed in Nidana, Pitta Ashmari either could be the uric acid stones or cystine stones, or it could be the stones which are presenting with the infective complications, where the patient would have chills, fever, urinary infections, etc. Then the Kapaja Ashmari, Gano Varunakadistu Gundulu Yela Harenamaha, Pusta Bhadradi Marita Chitrakaihi, Sasurato Hehi, Etehi, Siddham, Ajasarpi, Ushakadi Ganenaja, Bhinati Kapasambhutam, Ashmarim, Chipramento, Charan, Yabagun, Yushanscha, Kashayan, Payanscha. Bhojanani Chakurvita Varge Asmin Kapanashane. In the Kapaja Ashmari, the treatment protocol could be any of these Kapahara Aushadis, and as we have discussed earlier, either Kapaja Ashmari could be a phosphate calculus or it could be the staghorn calculus, right, which produces the obstructive symptoms than really infective symptoms. Then the other suggested drugs are Pituka Ankola Kataka Shaka Indi Varade Parehi. Churnite Sakudam Tuem Shakara Shamanam Pibeda. Shakara, the crystals produced either due to the breakdown of the stones or it could be the precursors to the stones, the crystalluria conditions. Then to prevent them, the yoga suggested is the Ankola, Kataka, etc. Again, Mutra Dravyas are considered. Or the other option is Krauja Usta Ratsabhastrini Kadamstra Alamurika Ajamoda Kadambasya Mulam Nagaramevada पीतानि शर्करां भिञ्जुः सुरया उष्णोदकेन वा the bones of certain birds like crown chavusra etc. or of the donkey's bones crushed and along with the drugs like Shodam Statalamdika etc. They can also be used for the stone to facilitate the stone, and these are consumed either with alcohol or with the warm water. त्रिकण्टकस्य बीजानां चूर्णं मक्षिकसंयुतं आविक्षीरेण सप्ताहं ashmari भेदं विभेद. Another simple yoga is a gokshura bija with the makshika, that's the honey, and the avikshira, in the milk of sheep. These are considered as one of the options of the ashmari bheda, and in folklore practice still it is one of the regularly practiced event, like the sheep's milk is considered or is given regularly to prevent the stones, or even given as a treatment of the stones in the folklore practice still. द्रव्याणां तु घृतोक्तानां क्षारो आविमूत्रगालितः ग्राम्य शक्रक्षारैः संयुक्तः साधितशनैः तत्र ऊषकादिः आवापः कार्यः त्रिकृतान्वितः एष क्षारो अश्मरीं गुल्मं शर्करां च घृणत्यपि. Another kshara yoga mentioned is the same all the dravyas along with the avimutra. Avimutra is the same sheep's milk, sheep's urine is considered to be another of the option. So sheep is one animal. Products of that animal is quite frequently used even in the folklore practice. Or gramya sattva shakra kshara is the sadidashani, along with the same kshara has to be used. Then another of the yoga is tila apamarga kadali palasha yavakalkajaha क्षारः पेयो अविमुत्रेण शर्करा नाशनपरः पाटला करवीराणां क्षारम् एवं समाचरेत् सदंसा यष्टिका ब्राह्मी कल्पं वा अक्षसमं वेद. Again another yoga with avimutra, that's the sheep's urine also is another of the yoga which is suggested. So sheep's urine and milk are considered, are regularly suggested as one of the options of the treatment in case of the management of calculus, maybe with an idea of preventing them. Then some more of the yogas are saha edakaksho peyo va shobhanjanakamapau, other options. Sushil has given you multiple options which could be considered as dietary supplements and regular practice, and any of these dravyas, shobhanjana, also can be used as a preventive one. Then kapotavankam moolam apibe raplehi sudadibhi tatsiddham apibe kshiram vedanabhi upadradha. To reduce the pain, another of the yoga mentioned is kapotavanka and with the sura. हरितक्यादि सिद्धम व वर्षाभू सिद्धमेव च. हरितक्यादिगण or वर्षाभू, that's punarnava also is another of the drug which is used. Or sarvacha upayogya syat gano virataraja, virataradigana also is used for the prevention of the ashmari. घृतैः क्षारैः कषायैश्च क्षीरैः स उत्तरवस्त्रिभिः यदि नोपशमं गच्छेत् चेदस्तत्र उत्तरो विधिः. Now these are all the suggested medical management, and if these medical management like Grita, Kshara and Kashaya or Kshira or Uttarabasti fail to produce the results or fail to prevent the cure, then only the surgical indication is suggested. Now as far as the medical management in case of the urinary stones are concerned, now in the present day situation there is a very little scope for the medical management, but the general options in the current contemporary medical practice will be in the patients of stones with the hypercalciuria, where the calcium level is increased. In such conditions, the suggestion would be sodium moderation and protein moderation. At the same time, diuretic like hydrochloric acid or indapamide or with the potassium and alkali are used. In the patients who have a lesser citrate levels, hypocitraturia being a cause for the stones, potassium citrate is given as such. Then hyperoxaluria, those who have a excess of oxalate content there, in such conditions pyridoxine is even prescribed as such. These are all the options of the medicine treatment. In patients with the hyperuricosuriasia, that's uric acid stones, allopurinol is often given, and patients with the low urinary pH, acidic urea as such, then potassium citrate, alkalizers are given. Alkalizers are generally given in the patients of stones as a general usual, like cystinuria conditions, potassium citrate or dipenicillamine also is given, and the patients who have infections, antibiotics of choice are the usual prescription. This is about the scope of medical management in the these stones, urinary stones as such. Now, from the clinical management point of view, now of course all those yogas mentioned in Sushruta are very much relevant, but in a practical clinical situation where you need to prescribe some simple medicines, based upon my clinical observations, my usual prescriptions in sub 10 millimeter stones. Now, my criteria is if the stones are more than 10 millimeter and if there are gross obstructive signs, then I will not manage the patient with the medical management. There has to be interventions. The intervention options, we will come to that later. Then the medical management is limited to sub 10 mm stones, irrespective of their location, whether it is in the lower pole or upper pole of the kidney. We can manage satisfactorily with these prescriptions, and the prescriptions would be when the patient presents with the colic pain like renal or ureteral colic, I will consider as Vatadika Lakshana, and my prescriptions would be Chandraprabha Agnichundi Avivartika. If there are static stones with the relatively lesser pain and there are certain obstructive signs as maybe mild hydronephrosis, not severe, I would consider them as the Kapaja, and in such conditions my prescriptions would be Chandraprabha, Punarna and Mustarika. And the stones with the infective symptoms, where the patient may have that fever, chills or pyuria like conditions, usually my prescription will be Chandraprabha Mrityunjaya Amrarishta or Chandraprabha Dandakarasayana with Chandanasava, Pittaja Lakshanas. When the patient has more fever and chills, it is a Mrityunjaya Amrarishta, and the patient has more pyuria, in that condition, Dandakarasayana and Chandanasava with Chandraprabha is the usual prescription. Patients who tend to have recurrent stones, in that condition, to prevent the stone formations, once the stones are expelled out by maybe lithotripsy or other interventional procedures, my preference of the treatment would be Chandraprabha Arogyavati Kumaryasava, though the Virechana is another option. Many of the patients may not be ready for Virechana. If the patient is ready for Virechana, a regular Virechana like once in a year or so also is one of the very useful preventive methods by which the incidence of the stones, recurrence of the stones can be effectively reduced. But if the patient is not ready for Virechana, then usually I prescribe Arogyavati Kumaryasava Chandraprabha as an alternative, as a Pachana chikitsa instead of the Shodhana. Then the other lifestyle suggestions would be plenty of water, avoid junk food, and regular Virechana. These are the suggestions by which the majority of sub 10 millimeter stones can be managed. Then comes the question of intervention. Sushruta has suggested a surgical treatment in case of the larger stones which have failed to resolve to the medical issues, and there the surgery is considered as a high risk surgery, and that's why Sushruta says Kushalasyapi Vaidyasya Yatha Siddhihi Iha Adruva Upakramo Jaganyam Ayam Atas Samparikirtitah Akriyayam Dhruva Mrityu Kriyayam Samshayo Bhed Tasmat Aprachyakartavyam Ishwaram Sadhukarena. In the surgical treatment, the outcome is unpredictable, and because of the unpredictable outcome, it's considered as one of the inferior method of intervention. So surgery should be limited to only those conditions where if there is no intervention, there is a definite certain death, and after intervention at least you have a fair chance of survival. So when there is such a critical issue of either death or a option of survival, in such conditions surgery has to be done, and that surgery has to be done with the legal protocols. Legal permission is required. Then the protocol, the procedure of doing the surgery is Atha Roganmitam Upasnigdam Apakristadosham Ishat Karshitam Abhyaktasthina Shariram Bhuktavantam Kirtabali Mangala Swastibhajanam Agropaharaniyaktena Vidhanena Upakalpita Sambharam Ashwasya. Tato, now this about the preparation. Once you have decided that the surgery has to be done, then before the surgery, the patient has to be given some shodhana, and then again the same controversy which we have discussed earlier, like Bhuktavantam, the patient is given light food, whereas in Sutrasthana, ashmari also is included in the Bhuktavataha, and whatever the discussion issue we have discussed in case of the Chikitsa, same hold good, that about the choice of the food as such. So I will not repeat the same. Then you have to prepare all the preparations for the surgery, and the patient has to be brought to the operation theatre. There, the positioning of the patient. to position the patient tato balavantam aviklavam आजान समय फलके प्राग उपविष्ट अन्य पुरुषस्य उत्संगे निषण्ण पूर्वकायम उत्तानम उन्नत कटिकम वस्त्रधारक उपविष्टम संकुचित ध्यानपूर्वकम इतरेण सह अवबद्धम सूत्रेण शाटकैर्वा. The positioning is exactly what we call as a lithotomy position, almost the same as in case of the chikitsa. The table used by Sushruta for surgery is a knee height table, and the same point, like because the surgeon would sit and do the surgery during that period. Now the situation is different. Surgeons prefer to stand and do the surgery, and there it is about the hip height tables. So the tables of Sushruta period were of knee height, and a assistant would sit on the table, and the patient is made to lay down on the lap of the patient with the lap of the assistant, and with the flexed thighs, and the flexed thighs are fixed with a cloth. It's exactly the lithotomy position, after making the patient in a firm position in that situation, then the surgeon would start with the procedure. The procedure would be tadaha swabhyaktanah pradeshasya vamparsvam vimradya mushtina avapidayat adho nabihe yavad ashmari adhaprapanna iti ततः स्नेहाभ्यक्ते क्लृप्तनके वामहस्तप्रदेशिनी मध्यमे अङ्गुल्यौ पायौ प्रणिधाय अनुसेवनीम् आसाद्य प्रयत्नबलाभ्यां पायु मेढ्रान्तरम् आनीय निर्व्यलीकम् अनायकम् अविषमं च बस्तिं च निमेष्य भृशम् उत्पीडयत् अङ्गुलिभ्यां यथा ग्रन्थिरिव उन्नतं शल्यं भवति. Now the protocol next would be to after positioning the patient, the surgeon would be having lubrication over the whole of the abdomen area, apply some lubrication, and press the abdominal area and press down over the suprapubic region in such a way that the stone is projected towards the perineal area. Now this kind of a proposition is possible when the stone size is quite huge. See, in the moderate stone sizes, this cannot be possible. It may not be possible. So you need to consider the indications of the surgery in Sushruta, where a bladder stone which is quite huge and produces a critical situation. In that condition only surgery was done. So in the present situation, when we can identify the stones with the investigations like ultrasonography or X-ray, and the relatively smaller stones like 1 or 2 centimeter size stones, it may not be possible to get into this protocol of pushing it down and making that stone prominent in the perineal area. But only in the large stones this could be possible. So in the present situation, these steps may not look relevant, but we need to look at the issue considering Sushruta indication and the time period of doing the surgery in Sushruta period. So once it is pushed down, the surgeon has to put the fingers into the rectum and attempt to pull out or again push the stones with the same in the perineal area. So the stone is made to be more prominent in the perineal area, so push it down towards the neck of the bladder, and once it becomes prominent, then you need to go for the incision. Now during this period during this maneuvering, because it produces quite a huge pain, patient may have a neurogenic shock. So Sushruta says this is the situation where the patient may go into neurogenic shock. Observe, and if the patient goes in neurogenic shock, revive the patient. Sachet grihita shalletu vivritaksho vichetanah hatavat lambashishashya nirvikaro mridopamah natasya nirharet shalyam nirharettum riyetu saha vinat peteshu rupeshu nirhastum prayateta vai. During this procedure, because of the pain, patient may go into the neurogenic shock, and the signs of the neurogenic shock, another quite important issue, signs of the shock are where the patient may have the pupillary reflexes affected, vivritaksha, where the eyes would not be responding to the stimuli, or vichetanaha, where the patient may have impaired consciousness, or his writing reflexes, the reflexes of the body to keep the organ in position, like the neck and head and neck, it may become more relaxed, like hanging down. That's the writing reflexes. The tone of the muscles would be lesser. Now grading of unconsciousness as in the Glasgow Coma scale and the criteria, and grading of the shock in Sushruta. They are of the same category. Only the thing is, in the Glasgow Coma scale, we have more objective subtypes, like where you have grade 1, 2, 3 for the speech, grade 1, 2, 3 for the visual input and visual outputs, and so on. So you have more objective analytical approach, whereas Sushruta has given a gross approach. So once the patient has gone into the shock like, then you have to avoid the surgery or maybe postpone the surgery. You are not supposed to do the surgery at that moment, because that can result in a fatal complication. So if the patient is otherwise fit in such a condition, सर्वे पार्श्वे सेवनीं यवमात्रेण मुक्त्वा अवचारयेत् शस्त्रम् अश्मरी प्रमाणम् दक्षिणतो क्रियासौकर्य हेतोः इत्येके यथा सा न विद्यते चूर्ण्यते वा तथा प्रयतेत चूर्णम् अल्पमपि अवस्थितं हि पुनः परिवृद्धिम् एति तस्मात् समस्ताम् अग्रवक्त्रेण आदधीत स्त्रीणां तु बस्तिपार्श्वगतो गर्भाशयः सन्निकृष्टः तस्मात् तासाम् उत्सङ्गवत् शस्त्रं पातेत अतो अन्यथा खलु आसां मूत्रस्रावी व्रणो भवेत् पुरुषस्य वा मूत्रप्रसेकक्षणात् मूत्रक्षरणम् अश्मरी व्रणात् धृते भिन्नबस्तिः एकदापि न भवति द्विधा भिन्नबस्तिः आश्मरिको न सिद्ध्यति अश्मरी व्रणनिमित्तम् एकदा भिन्नबस्तिः जीवति क्रियाभ्यासात् शास्त्रविहितच्छेदात् निश्चन्दपरिवर्धत्वात् शल्यस्य इति. Now, the whole procedure of the surgery would be, once the stone is made to be prominent in the perineal area, make an incision on either the left or the right side of the perineal line, the midline, and when you make the incision, you should be careful that the incision should not hurt the stone. The stone should not be broken down. The integral whole stone has to be expelled out through the perineal area. To pull out the stone, you may use an instrument called Agravakra Yantra. Agravakra Yantra, again, in the list of the yantras, Sushruta has not included that Agravakra Yantra in the 20 yantras. 101 yantras is not included. But these are certain of the other extras of the extra instruments which are mentioned. Now, when you do the perineal incision in the females, there is a possibility of the injury to the uterus, and that would be the perineal area of the females would have that extra organ there, and hence when you make the incision, you have to put the incision in an upper direction, on the superior direction, avoiding the uterus as such. Otherwise, there can be a complications as such. Complications could be Mutrasravi Bruno Bhaveta, there could be a wound which continues to have the urinary leakage which may not heal, and or there could be injury to the urethra, Mutra Prasekakshanata, there could be injury to the urethra in Purusha, in males, and hence there is a possibility of a continuous leakage of the urine, or there is the important is the opening may not heal easily. Now, this perineal approach to the bladder stones was a regular practice even in the Western surgery till very recent, till 18th century, till 19th century, it was the standard practice. And that's why the word lithotomy and the position of lithotomy is the popular one. See, lithotomy is the word which suggests about the surgery for the stones, and the position of keeping the legs flexed is, and making the perineum prominent, is that position is called as lithotomy position. In the present day situation, of course, no one does the surgery in a perineal approach for the stones as such. In the bladder, we always prefer, if at all surgery has to be done, we always prefer suprapubic approach. And these advantages and disadvantages are, see, suprapubic approach was possible only after a proper knowledge about the perineal avulsion or peritoneal avulsion during the distended bladder. See, suprapubic incision can be done only when the bladder is distended with the fluid in. So when we do the suprapubic incision, we always put in a catheter and fill the bladder with saline, and when the bladder is full, then we make the incision so that the incision doesn't reach to the peritoneum. If the bladder is not inflated, then you cannot reach the bladder without injuring the peritoneum. So that knowledge that you can reach to the bladder without injuring the peritoneum came up only in the later part of the 18th century and 19th century, early phases of the 19th century. And till then, in the Western surgery, the perineal approach, exactly the same procedure mentioned by Sushila was used as the surgery, and that name, lithotomy position, still continues now. Even now, we use that name, call that position as lithotomy position, though we never adopt that position for the surgeries of the bladder. But lithotomy positions are used for either obstetric practices or anal surgeries. That's the practice now, but the name continues as lithotomy position. That's the issue. Now, the advantages and disadvantages are the major disadvantage of the perineal incision is because it involves the neck of the bladder. There is always a high chances of the failure of the union and the leakage of the urethra, or loss of control of the urinary flow would be one of the major issues. But in the earlier days, there was the only means by which the peritonitis could be avoided. With the suprapubic approach, if accidentally you rupture the peritoneum and there is a leakage of the urine into the peritoneum, it can produce widespread peritonitis. That's a major issue. Otherwise, suprapubic is definitely more convenient than the perineal approach, and that's why suprapubic is more common now. So anyway, that's about the perceptual differences seen due to the experiences and so on. Now, the basti is considered as a sadhya pranahara, and injury to the basti can be fatal. But injury to the basti during surgery, a surgical incision in the basti may not result in a fatal complication. Sushil says because of kriyabhyasat, shastra vihita chedat, nischanda parivardhatvat shalles. Yeah. Because the surgeon would be doing the incision where he will be saving that vital structures to a great extent, and hence the injury produced due to a accidental trauma is different from an injury produced by a surgeon, and hence even though it's a sadhya pranahara marma, it may not result in a fatal complications. And because it's also done by many your peers, seniors have done that, and traditionally that kind of incision is made, and hence you can be assured that it may not be fatal. And if you do not make the incision, it can result in a fatal complication, and hence it should be done. And if at all it has to be done once, then the patient would survive. But a repeated incision in the same area can produce fatal complication. This is the caution given by Sushila when you make the incision. So there should be no chance of recurrence. Chance of recurrence are very high if the stone gets crushed and even a part of the stone is left in, which can act as a needles for the further stone formation. That's why Sushila insists on a complete removal of the stones. Even a small particle of the stone should not be left over. So that's about the cautions during the surgical protocol. Then once the stone is removed, next the post-operative care would be Utrata Shalyam Tushnodaka Dronyam Avgahya Swedayet Tatahi Basi Asuja Napuriyate Purnema Kshira Vrukshakashaya Pushpanetrena Vidadhyata Bhavati Chatra Kshira Vrukshakashayastu Pushpanetrena Yujitaha Nirhare Ashmari Churnam Raktam Bastikalam Jeta. One of the major complication in all the bladder surgery is the blood clot may get filled in the bladder, and that's why now we prefer to have a irrigation, continuous irrigation for at least a few hours after the surgery, and we usually prefer a 3-way catheter, and with the 3-way catheter continuous irrigation is done. Now Sushila has suggested that irrigation by keeping the patient dipped in a udakadroni, in a boat-like vessel which contains warm water, so that there will be irrigation. The principle is the same. Of course, I agree that our 3-way tube is much more convenient than a possible option of dipping the patient in a this vessel containing water. But Sushila had suggested that, but principle is the same. Principle of keeping the bladder irrigated so that the clot would not form is the same, and that's a surgical issue. Tatahi basti asrajana puryate purnema kshirakashayam pushpanetrena vidadhyata. That should not be. Now, by this irrigation, it may not be the bladder may not be filled with the hematoma. If at all the hematoma occurs, then with a catheter, you have to put in Kshiravruksha Kashaya. Kshiravruksha Kashayas would be reducing the possibility of the clot as well as possibility of recurrence of the stones. Then further, in the post-operative period, Mutramarga Vishodhanartam Jasmi Gudasahrutyam Vidaret, Uthritya Chayanam, Madhukruta Abhyakta Vranam, Mutra Vishodhana Trapesiddham, Ustam, Sadhritam, Yavagum, Payeta, Ubhayakalam, Triratra Durdvam, Gudapragadhena Payasa, Murtodhanam, Alpam Bhojayet Dasharatram, Mutra Asra Vishuddhyartam, Vranakredanartham cha, Dasharatra Urdvam, Palamdehi, Jangalarasehim Pacharet, Tato Dasharatram Chainam, Apramatta Swede, Snehena, Dravasvedena va, Kshiravruksha Kashayana Chasya Vranam Praksharet, Rodra Maduka Manjista, Propoundarika Kalkehi Vranam Pratigrahayet, Yeteshveva, Haridra Yiteshu Tailam, Ghatam cha Vipakvam Vranabhitnanam iti, Styanashonitam cha Uttarabastibhi Upacharet, Saptaratra cha Samarga Pratipadyamane Mutre, Vranam Yathoktena Vidyana Dahet Agnina, Samarga Pratipanya cha Uttarabasti Asthapana Anuvasane Upacharet Madhura Kashayi iti, Yadrichayava, Mutramarga Pratipanna Mantarasaktam Shukrashmarim Sharkara Sotasa Aparet, Evam cha Shakke, Vidaryanadiim Shastrena Badishena Uddhareta. In the post-operative period, the maintenance of the nourishment and fluid intake of the patient is one of the important criteria. First 3 days, the patient has to be given only Gudasauhitya, that is, which is rich in glucose, the jaggery and then jaggery preparation. Now, of course, we may prefer intravenous fluids. The idea is providing high amount of nourishment with lesser volume, and social says Gudasauhitya, the jaggery, which is a real source of the glucose, the energy, in small quantities it can be given. Whereas now we have a better option of giving IV fluids where there is no need of that adding the volume into the gastrointestinal tract. So that's it. Then the wound care has to be done. The wound has to be treated with the madhukrita, and it has to be covered, put a bandage over the area. And for after Triratram, after the 3 days, then you have to give milk with the slight rice, mridvodana and milk. Small quantities of that given for 10 days, next 10 days. Then after 10 days, patient has to be given more nourishing food and maybe heavy food like pala fruits or jangalarasa, mamsa, soup, etc. for after 10 days. And during these 10 days, to promote the healing, snehana, swedana has to be done. And if the wound has to be cleaned with the Kshiravruksha Kashaya, and it has to be applied with the kalka of Rodra Maduka Manjista, etc. And Haridra also, even Taila or Ghruta also can be used for Brana, the wound healing. If at all the patient develops a clot in the bladder, scan shows the myth, there is a hematoma formation, then that has to be treated with Uttarabasti. And ideally, in an ideal condition, by 7 days, that incision would heal and the patient would be able to pass the urine through the urethra. The opening should heal. If the opening doesn't heal and the urine continues to leak through the wound in the perineal area, it can be cauterized. Cautery is suggested, the Dahet Agnina, and once the patient is able to pass the urine through the urethra in the normal passages, then the patient is given Uttarabasti or Anuvasana Asthapanasti, so that the healing would be better and there would be no recurrence. During this procedure, if at all some soft substance, now Sushil says Shukrashmari, about Shukrashmari also we have discussed earlier, it may not be the semen as such, it could be some products of the inflammation. Soft substances block the urethra, they need to be removed, pulled out, or a crystal piece also, if at all it is blocking the urethra, that needs to be pulled out. If it cannot be pulled out, then a ureterotomy may be required. You have to slit open the urethra and then remove that with a Badishentra. Now, it shows Sushruta has planned that surgical post-operative protocol very methodically and relevant in the older situation. All these steps may not be relevant in the present day situation where you have totally different set of facilities, but many of these issues may be critically useful in certain complications of the wound healing. So we may pick out any of these whenever there are certain unexpected complications which can be useful. So they are relevant in such conditions, may not be in the routine practice. Then once the wound has healed, patient has to take care for about a year to prevent the recurrence and or prevent the dehiscence. So any rigorous activity like Rudra, Angana, Ashwa, Naga, Ratha, Druma, Naroheta Vrisham, Napsuplaveta, Bunjitava Guru. During 1 year, you should not have rigorous activity like sexual activities or traveling on vehicles like or climbing a tree or swimming in water. These should be avoided. Then Mutravaha, Shukravaha, Mushka Sroto, Mutra Praseka Sevani, Yoni Budabastin, Astau Parihareta. The 8 important structures which are very close to the bladder or very close to the basti has to be avoided during the surgery, and possible complications of collateral injury to these structures could occur. Mutravachchedat Maranam Mutrapurnabistehe. Mutravah srotas are the ureters, and injury to the ureters during this surgery can result in fatal complications. Death can occur. Shukravachchedat Maranam Traibhyamva. Due to Shukravah, that's the seminiferous ducts injury, the patient may have again either death or impotency. Mushka Srota Upadhatat Dhwajabaddaha. There could be injury to the either the penile structures or could be the testicle area. Patient may have again impotency as such. Then Mutra Praseka Ksharanat Mutra Praksharanam. Due to the injury to the urethra, the patient may have a leakage of the urine, continuous leakage of the urine. Sevani Yonichedat Rujaha. Due to the perineal line, injury of the perineal line, mid-perineal line, the patient, it may not heal. Mid-perineal line would have more fibrous structures and healing would be delayed, and hence the patient may have continuous pain over there. Bastikuta Vidhalakshanam Pravuttam, the possibility of injury to the anus and the bladder like Sadhya Pranahara, they are already mentioned. Hence, Marmani Astau Asambudya Srotojani Sharirana Vyapade Bhun Matyan Shastrakarma Apatuhu Bishaka. A person who is not skilled in surgery may produce more serious complications due to the collateral injury of injuring any of those neighboring structures. Sevani, Shukraharani, Srotasi, Palayobudam, Mutrasekam, Mutravaham, Yonihi, Bastistata, Ashtamha. These are the 8 structures, again repetition of the same, which are very close to the bladder. Now, from the current point of view, the interventions in the urolithiasis could be of different options. It may not be only the surgery. There are many interventions which are done, and it's not like the decision is based upon only the type of the size of the stones, and the protocol is what we have discussed in the beginning, that 10 mm or more than 10 mm, and the lower pole or upper pole stones in the kidney, that would be deciding, and the bladder stones, again the guidelines we have discussed. And the issue, the options are now either it could be a stent placement by which the spontaneous expulsion of the stone may be possible, or percutaneous nephrostomy where the stone can be extracted out, percutaneous route, or extracorporeal shockwave lithotripsy, which is now becoming very popular. The lithotripsy has become now more popular option, where with the shockwave the stones are crushed and then smaller pieces of stones are facilitated to get expelled out either with a stent or without the stent. Then ureteroscopy, where it can be pulled out, the stone could be pulled out, or nephrostolithotomy or mini PMCL, where again it's a percutaneous nephrostomy, but instead of the nephrostomy, it's a nephrostolithotomy, directly making an incision over the stone and then pulling it out, or open nephrostomy, where surgery is done as such. Or it could be anatrophic nephrolithotomy, where endoscopic surgery is done. Then the other options which are often suggested, which are not the standard practices, are the hydration therapy. In a stone which is relatively less than 10 mm, one of the options which are not now considered as a standard protocol but still practiced is hydration. That's giving large volume of the fluid so that the stone may get expelled out. Usually you give 2 to 2.5 liters of IV fluids with a diuretic given so that the stone may be expelled out. But this kind of treatment has very limitations. The most important limitation is If the stone size is more than 10 mm, it may not be. Only 3 or 4 mm stones which are movable, then it can be effective. Only in the movable stones which have present with the colic. Stones which are static, which do not produce the pain, hydration would not be of much use there. But at the same time, there is another drawback. And the stones produce a renal colic. The stones in the kidney or the pelvis of the kidney, if they produce the colic, there will be usually a shutdown, temporary renal shutdown. The kidney would not be excreting, functioning temporarily due to the episode of the pain over there. And whatever the fluid you give would be excreted through the other kidney, and hence the whole treatment will be failure. But in a ureteric colic, if the stone is in the ureter, then the hydration therapy can be useful in expelling the stones. Giving large volume of the fluid may produce hypervolemia if the patient has already a pre-existing conditions like either cardiac hypertrophy, hypertension, etc. This can be a drawback. It can produce the complications. And the large volume of the fluid given also can be producing a change in the electrolyte constitution of the body. So, relatively delicate status of the patients. These cannot be tried, but still it is one of the usual treatment tried, though it's not considered as a standard protocol of the treatment now, hydration therapy. Then the other options which are often becoming more popular or somewhat popular are, there is a protocol called as postural therapy, where the patient is nursed in a specific position for a few hours of the day and massage over there, physical pressure over there. Again, not a standard practice, but still these are becoming popular. Another option is what we call as a push therapy, more modern type. Push is prevention of urinary stones with the hydration, and there the issue is patients who are prone to have the stones, they are given a smart water bottle with a smartphone which gives a message every hour that you have to drink water, to make the patient drink more water. This kind of issue is done, and these are becoming popular in the Western countries, but these are not again the standard practices. So you have multiple options of the management of the stones. With this, the other steps, general advice to the patients of the stones in the present day situation would be the basic steps to reduce risk of kidney stones are: drink more water, keep your salt intake as moderate, eat less meat, eat more of fruits and vegetables, keep a normal dietary calcium intake. And one of the important issues is the excess of calcium intake these days. This is one of the most common cause for the stones, and moderate your intake of high oxalate contents as such. Then the other recommendations which are suggested is sodium, providing sufficient amount of sodium, and protein, recommend amount of the protein. These are the usual suggestions which are given to prevent the stones in the current practice. With this, we conclude. इति सुश्रुतम् चिकित्सास्थाने ashmari chikitsa नाम सप्तमोऽध्यायः. If there are any questions, we will try to answer and then wind up. There are some questions like Virechana, any particular grita would be suggest. Now, of course, Gokshirati grita can be a better option, or plain grita also could be useful. Then up to which size the stone we can advise for Virechana. So, see, all the protocol is simple issue is, if the stone is more than 10 mm, then it cannot be expelled out. It cannot expel out through the passage, because the ureteral passage would not be able to push out a stone which is more than 10 mm, and hence that would be the criteria. Above 10 mm stones, intervention is required. So there is no question of waiting for that. That's about the issue. With this, let us conclude. Okay, no more questions. Thank you.